Introduction. I have been given a topic of rheumatologic manifestations in diabetes, and we do see that because though we are treating diabetes as such, we do see that other organs are involved, and it's very important to know about the rheumatologic manifestations and what we should do and what we should look for. So basically, rheumatic complaints are very common in patients with diabetes, and the only way to prevent them is to have a good glycemic control, exercise, diet, medication, and this will improve or prevent the development of rheumatic complications in these patients. So when we talk about rheumatic complication of diabetes, we can divide them into three groups. First is the complications which are unique only to diabetes. For example, diabetic muscle infarction is a condition which is seen only in diabetic patients, and just I think yesterday or day before yesterday the article on this came in JAPI, the current issue of JAPI. One case has been reported. So it's not very common, maybe in the whole world about 100 cases have been reported, but it is there and we should know about it. There are certain conditions which occur more frequently in diabetic patients like neuropathic arthropathy, limited joint mobility, stiff hand syndrome, Dupuytren contracture, trigger finger, shoulder capsulitis, acidic shoulder periarthritis, and carpal tunnel syndrome, and we'll discuss some of them in detail. And of course, there are certain conditions which share the risk factors both with diabetes and metabolic syndrome, like diffuse idiopathic skeletal hyperostosis or DISH, gout, and osteoarthritis. Now, if you compare the prevalence of musculoskeletal disorders in patients with or without diabetes, you will see that definitely the percentage of some of the disorders is much higher in the population who are diabetic as compared to those who are not diabetic. So if you see frozen shoulder, definitely much higher, 11 to 30% in diabetic patients, only 2 to 10% in non-diabetic patients. Limited joint mobility is very common in diabetic patients, about 50%, much less in people without diabetes. Dupuytren's contracture also very common in diabetic patients. Carpal tunnel syndrome is a little bit on the higher side, flexor tenosynovitis, and diffuse idiopathic skeletal hyperostosis. All of these conditions are much more frequent in diabetes as compared to those who don't have diabetes. The first thing we will discuss is frozen shoulder, because this is commonly seen in our diabetic patients, and it's a very disabling problem. Patient has got a lot of pain, a lot of restriction in the motion, and it is also known as adhesive capsulitis or shoulder periarthritis. It's basically characterized by progressive painful restriction of shoulder movement, especially external rotation and abduction, and patient says that there is severe pain, especially more in sleeping. The joint capsule is thick, is closely applied and adherent to the humeral head, and that's why this problem occurs. There are three phases in the history of shoulder periarthritis. First is the painful phase, where there is severe pain. Then there is an adhesive phase, and then there is a resolution phase. The incidence of adhesive capsulitis is associated with the duration of diabetes and age of patient. So elderly patients or patients who have got diabetes for longer duration have got more frequency of this condition. Now this is an X-ray which shows classically a contracted adherent joint in the second phase of periarthritis because it has not been managed properly in the first phase. Basically, the treatment is, again, the treatment of all these conditions is going to be by the orthopedic or by the physiotherapist, but our job is to diagnose it and refer them so that they are managed properly. So most of these cases will resolve over time. You have to tell the patient that it is going to take a lot of time for you to get alright. It's not a simple give some analgesics and it will be alright. Analgesics are very important. Physiotherapy is very important. Sometimes you need to give intra-articular steroid injections. Very important to remember that if the patient is diabetic, the steroids will increase the blood sugar for at least 1 to 2 days after the injection. Many times the orthopedic surgeons will give a general anesthesia and manipulate the joint so that the adhesions are released. And of course, very important to have a regular physiotherapy program which should be maintained after the painful phase is over, because in the painful phase, patient will resist the physiotherapy throughout the course of the condition so that there is a good relief. And there is very good relief if the patient waits and does the things which are told to him properly. Then we talk about the hand syndromes, which are much more common in patients with diabetes, both in type 1 and type 2 diabetes as compared to the general population. And there is an association between the hand syndromes and duration of diabetes, and the more the duration of diabetes, the more likely to be having the hand syndromes. This is one of the things which we know, we have heard about in the multiple choice questions, prayer sign, and basically it's the limited joint mobility, which is also known as diabetic arthropathy, which is characterized by thick, tight, waxy skin. The skin, if you look at it, is very tight, waxy, shining skin, mainly on the dorsal aspect of the hands, and there are flexion deformities of the small joints of the hands. So when the person puts both the palms together, you cannot oppose both the palms. I'll show you a photograph, and as though the person is praying, so it is known as prayer sign. Initially, there is paresthesia, and the pain is very slight, but if you don't intervene, if you don't treat, then the symptoms will increase, the pain also will increase. Commonly, you will find that a person who is having limited joint mobility also has Dupuytren's contracture, so these two things may coexist. And again, very important to have a good glycemic control and a proper physiotherapy program. So this is the photograph of the prayer sign, as I told you. On the left, you can see normally we will be able to oppose our palms, but in the person with this condition, there is a flexion deformity of the joints, and because of that, they are not able to oppose their hands. Then the next thing is the Dupuytren's contracture. This is also very common. Is the palmar or digital thickening or tethering or contracture of the hands. Again, I'll show you a photograph of that. In patients with diabetes, again you can distinguish between a diabetic and non-diabetic person, because in patients with diabetes, the ring and middle finger are more commonly affected, while in those patients who are not having diabetes, it's the small finger or the fifth finger which is more commonly affected. Again, treatment is good glycemic control, very important, physiotherapy, hand exercises, and sometimes if there is a very severe contracture, then you will need surgery. And this is the photograph which shows the progression of Dupuytren's disease. Initially in stage 1 there is only a nodule where it is known as Dupuytren's disease, and then as it progresses to grade 2 there are cord formation, and then there is a flexion contracture, then it is known as Dupuytren's contracture. So initially when the person comes with a nodule on the palmar aspect in the two fingers which I mentioned, you should think that this is the beginning of the Dupuytren's disease, and you should not allow it to progress to the contracture. Then we talk about carpal tunnel syndrome, and we know that it is quite common in hypothyroidism, but please remember that it's also common in diabetic patients, and it's characterized by paresthesia over the median nerve cutaneous distribution of the thumb, index, middle and lateral half of the ring finger, which is often worse at night. Again, I'll show a photograph of this. The symptoms are caused by compression of the median nerve within the carpal tunnel, and there could also be a component of diabetic neuropathy, because we know that these people, diabetic people, may also have neuropathy. So sometimes it's a combination of both. So you may need to give a drug for the neuropathy, and you may need to do something for the carpal tunnel syndrome. It's more common in women than in men. Basically, initially when the patient comes, you have to give a simple analgesic splint which the patient should wear throughout the day. Sometimes you may have to give a local steroid in the milder cases. But if the conservative measures fail, then you need a surgery to release the nerve and relieve the symptoms. And this is the photograph which shows that the transverse carpal ligament traps the median nerve and the area of distribution of the symptoms classically, which you see in carpal tunnel syndrome. Then there is very important thing which happens is trigger finger, which is known as flexor tenosynovitis, which is caused by fibrous tissue proliferation in the tendon sheath, which leads to limitation of the normal movement of the tendon, and it's associated with the duration of diabetes but not with age. And usually to treat it, the orthopedic surgeon will inject a corticosteroid injection into the flexor tendon sheath. Again, I'll show you a photograph of this. And this is basically, as though you are pulling the trigger, the tendon is swollen and the finger is bent, and it resembles like the motion of pulling the trigger in the gun. Then this thing which we fail to see very often but which is occurring is a reflex sympathetic dystrophy, which is also known as Sudeck's atrophy, and it is characterized by localized or diffuse pain associated with swelling, with trophic changes, vasomotor disturbances, and impaired mobility of the affected region. Because autonomic involvement is also there in this, may occur spontaneously, but usually it occurs after a small surgery or a fracture or a trauma. The patient goes in for Sudek's atrophy. Again, very difficult to treat. This is not a condition where any treatment really works. There is a lot of anecdotal evidence for analgesics. Some people say physiotherapy, IV bisphosphonates, calcitonin, steroids, sympathetic ganglion blockers. Treatments don't work, but the prognosis is good, though some people may end up with a chronic pain and contractures. And this is a photo to show that. You can see that because of the autonomic changes, there is a shiny skin, and classically you can see the changes. Then there is another very important condition which is known as diffuse idiopathic skeletal hyperostosis, which is also known as ankylosing hyperostosis or Foster's disease, which is characterized by new bone formation in the thoracolumbar spine. It's more prominent on the right side of the thoracic vertebra, we don't know why. There is ossification of the ligaments, ossification of the tendons in the skull, pelvis, heel or elbows. So all the tendons, the connective tissue will become ossified, there will be bone development. Initially they may have mild stiffness on arising, and they may also develop dysphagia. So dysphagia is a patient with diabetes. If there is an ossification of the spine, then it is because of this. In some cases, affected persons have normal mobility of the spine. They may be asymptomatic. If you take an X-ray, you will find that it is just incidental finding. Again, good diabetic control, education and physiotherapy. And this is the photograph of the dish. You can see that on the left, the spine is normal, but on the right, lot of new bone has deposited on the ligaments, and this is extra bone deposition, and this can be seen very clearly on an X-ray. This is just a diagrammatic figure. Then we know about Charcot's foot. Charcot's joint is a result of diabetic peripheral neuropathy. There is a reduction in the normal protective neural impulses, leads to loss of protection from trauma. There is a painless joint destruction. Initial warmth and erythema will mimic osteomyelitis or arthritis, but very importantly there is no fever, the white cell count is not elevated, ESR is not elevated, so it should not be treated as an infection, it should be treated as a Charcot's foot. Again, you have to give good glycemic control, and very important to give rest to the foot, should be seen by a good foot surgeon who treats diabetic feet, and sometimes you may need to do surgery. And again a photograph to show what happens. This is the healthy foot, and then all the joints have collapsed, there is destruction, and this foot is totally gone. So we should not allow this to happen, and as soon as the acute stage comes, it's very important to diagnose it and treat it. And then we'll come to the last condition which I told you has been reported in JAPI. Very rare but just important to know. It's a disabling illness that is distinct from any other form of diabetic neuropathy, characterized by muscle weakness and wasting, and by diffuse proximal lower limb muscle pain, symmetrical loss of tendon jerks. Shoulder girdle may be affected but less commonly. The exact cause and incidence of diabetic amyotrophy is uncertain. It's a diagnosis of exclusion. We should think of other causes, paraneoplastic syndrome, or occult malignancy which could be producing this, or some other condition, because there will be new neuropathic signs, there will be weight loss. So it's just not a simple thing that you diagnose. You have to exclude other causes. Again, as I told you, you have to stabilize the glycemic control, physiotherapy. Some cases will improve, but improvement is very gradual and patients are not satisfied. And this is a picture of the painful muscle wasting which is seen in diabetic amyotrophy.
Thank you, sir.
Yeah, thanks.